Welcome to another X Space hosted by Democrats for an Informed Approach to Gender. DIAG is a 501c3 organization. Our mission is to shed light on the harms of gender ideology. We're opening the eyes of fellow liberals to the erosion of women's rights and the medical scandal known as gender affirming care. If you'd like to learn more about us, go to our website. That's diag.org. That's di-ag.org. And while you're there, check out our merch store. And if you'd like to help us out, click on the donate button. Today, we welcome back two guests, researchers M. Lal and psychiatrist Dr. Lauren Schwartz. They're here to talk about their latest paper, published in the Journal of Sex and Marital Therapy. The title is a bit of a mouthful, Order of Magnitude on the Critical Distinction Between Self-Reported Identity and Clinical Prevalence in Adolescent Gender Dysphoria, a Methodological Commentary. So in a nutshell, Drs. Lal and Schwartz found that gender clinicians have conflated many people who claim a trans identity with those suffering from a clinically significant condition known as gender dysphoria. Consequently, doctors are medicalizing far greater numbers of patients than would have been prescribed hormones or surgeries in the past. Thank you for joining us, Dr. Schwartz, Dr. Lal. Good to hear from you again. Dr. Lal is a member of our DIAG team, and we refer to him as ML, so that's how I'll be addressing him here. Okay, so before we delve into the study, I do want to make something clear. So neither of you are advocating for medical interventions for altering the bodies of any people who feel uncomfortable about their sex. So let's clarify that. You're not suggesting that there's some special cohort of patients who would necessarily benefit from hormones and surgeries. Am I correct about that, ML?
Yeah, that is correct. We are not making any special claims about that. And to be clear, our paper isn't about our personal opinions on medicalization. It is what we would call a friendly fire critique. So we did not use data from critics of gender medicine. We looked exclusively at the data provided by the affirmative establishment's own leaders and the biggest leaders out there. We simply asked, what do the WPATH related experts, including past presidents and current authors of their latest standards of care, the people who wrote the latest guidelines, say is the actual prevalence of people requiring medicalization? And then we compare that number to the number of kids they are actually medicalizing. And that, again, might be an undercount, but we can get to that later.
Okay, great. Wanted to get that out right out in front. So thanks for clarifying that for us. So earlier this year, we started to see some statistics on the number of young trans-identified patients who have received puberty blockers and hormones. So JAMA Pediatrics published a study. There were some other numbers coming in. Can you tell us about those numbers? Why don't you keep going?
Right. So January this year, January 6th this year, a team led by Landon Hughes at Harvard looked at, they published that paper, it came out that day. They looked at private insurance data, and they looked at the number of children and adolescents getting the diagnosis for, some gender-related diagnosis. And they concluded that roughly 1 in 1,000 American teens, or 0.1%, had received puberty blockers, or more specifically hormones, by the age of 17. And they immediately, and the media, in fact, the NPR on the very same day published, had a report framing this as a very, very small number. I'm quoting them, and essentially told the public, move along, there's nothing to see here.
Wow. Okay, so 1 in 1,000 does not seem small to me. That seems kind of
Yeah.
horrifyingly large, considering that I don't think any of us knew any kids who were getting these interventions, you know, 10 or 15 years ago, and certainly not when we were all younger. So, um, yeah, so if you could, ML, if you could compare that figure, the 0.1% with what you and Dr. Schwartz found when you looked at the research.
Okay. So this is. I mean, I was trying to think of this. Let's say Philip Morris came out with an argument which said there are 340 million people in the United States, and 100,000 die of lung cancer from smoking every year. So divide 100,000 by 340 million, and that's like 0.03% or whatever. Okay. So if you use a large enough denominator, the number, then anything could be made to be a very small number. So this 1 in 1,000 is not small, because what they're comparing this to, the denominator, is all the uh, children in the US, all the adolescents in the US in the 13 to 17 age group. Um, so, in fact, this number is massive in the sense that we looked at three major literature reviews published between 2015 and 2019. And these reviews were published by people who wrote the WPATH guidelines. These are the doyens of the field. I mean, these are not gender critical people who are coming and claiming something. And these reviews, based on more than 50 individual studies in different countries, different times, from 1970s all the way up to the 2010s and beyond, uh, they tried to find what is the true clinical population according to their guidelines. So these are the needle in the haystack who suffer from genuine, persistent gender dysphoria. Okay. And these reviews consistently found that the clinical population is between 5 to 7.5 per 100,000. So, so do the math. The JAMA paper found that the medicalization rate was 100 per 100,000. And depending on which number that you're looking at from these WPATH WPATH expert reviews, this number of adolescents getting medicalized is 13 to 22 times higher than the field's own clinical baselines. Okay, so it means that by their own standards, and when they are, diagnosing it, and within the records uh, uh, for insurance purposes, when they're diagnosing as gender dysphoria by their own standards, over 93% of the kids currently being medicalized, or at least in 2022, fall outside the clinical population these treatments were ever intended for. And that is not according to us, that is according to the WPATH guidelines.
Okay, so first, who are the clinicians that are the researchers that are making those estimates? Who are we talking about?
So these are titans of the industry. I mean, we counted 10 different authors of WPATH Standards of Care 8, that one that came out in 2022 with all the scandal associated with it. But let's not go there. Let's just assume for a moment that they know everything about this. So we counted 10 different authors of this WPATH Standards of Care 8. This includes Eli Coleman, the lead author of that standards of care, and a past president, member of the board. It includes Walter Bauman, a past president of WPATH. It let's see. So there are 8 more people, including people who have collaborated with Jack Durbin several times. So these are people who they are the ones who came up with these numbers, not us.
Okay. And
Well,
so
and just to add to that before we move on, one thing to look at is you're not talking about number of children diagnosed. You're talking about number of children medicalized. And so when we look at what medicalization means in this particular field, in this quote unquote gender affirming care field, you're talking about life altering, permanently modifying treatment interventions that are now being given to kids, and we can talk all through some of those complications, but the idea is there's never a number small enough if children are being harmed by such treatments. And so I think that's important to keep in mind too. You think about the point of why they would say something along the lines of, well, this is such a small number of individuals being treated, by these numbers. So let's just, like you said before, nothing to see here. And I'm sorry, in medicine, harm being done to patients at any degree is significant.
so so let's okay, first I want to go back for I'm sure people know, but just in case they don't, WPATH, so that stands for the World Professional Association for Transgender Health. These are the folks who put out the quote standards of care. They are the, as ML called them, titans of the gender industry. And so we're talking about kids who were actually medicalized. These are kids who received treatment, but does that mean that they are diagnosed as having gender dysphoria, or are they treated? Maybe you can explain a little bit. So, out of those, um, the ones that could be considered clinical, um, clinically treatable, so in need of medicalization, what is that designation based on? What are the criteria that they're using for that diagnosis?
Sure. So when you look at, and truly we're going to kind of follow the same I think path that we did when we were looking into these numbers. Not look we took actual that we actually looked at the standards of care 8, for example, and you look at their criteria. Now, whether or not each individual clinic and each individual doctor who are publishing these things, whether or not they're actually following these, that's not what we're commenting on. But when you look at actual SOC 8 criteria, for hormones, for example. I mean, we could read through them. They look and walk very much through what the DSM-5, our Diagnostic and Statistical Manual, says about gender dysphoria. However, there's somewhat of a shift when you look at their criteria. So I can just read to you like criteria for hormones, for example. It says gender incongruence. So note already the shift. Gender incongruence is marked and sustained, meets diagnostic criteria for gender incongruence prior to gender affirming hormone treatment in regions where a diagnosis is necessary to access healthcare, demonstrates capacity to consent for specific gender affirming hormone treatment. Other possible causes of apparent gender incongruence have been identified and excluded, and they walk through criteria and then criteria for surgery. So there is actual criteria in the standards of care 8 that they present. So that's supposedly what they're following.
Okay, but there's no test, and it's not some of those things. These are fairly subjective, and it sounded like, especially that first item, was about like you get the diagnosis in order to get your interventions. Was
Sure. And maybe it would help to kind of back up a little bit. So, just in terms of mental health and mental health diagnoses and psychiatric diagnoses, truly our diagnoses are a lot of times diagnoses of exclusion. And what I mean by that is we do look at a full biopsychosocial approach to um, our intake of, let's say, a new patient, and we look at we got to rule out medical issues that may be presenting as something psychiatric. We look at whether or not there are contributing factors to what's going on. And I think especially in this area, what's been different is the focus has been on distress, i.e. gender distress or distress related to gender versus um, kind of the underlying psychiatric diagnoses that maybe we would have looked at before, if that makes sense. Um, and so there is, like you said, there's this shift in, well, here we just check boxes, and if we meet that, then we get treatment. And that's truly not how diagnoses in any mental health setting works. If I'm answering your question.
Yeah, and something else that you read, they talked about gender incongruence. So they didn't talk about gender dysphoria. They're talking about gender incongruence. Can you define that and tell us what's different?
Sure. Well, and so it's interesting. So what we look at, and maybe it also helps to back up kind of historically, and we look at the evolution of the diagnostic and statistical manuals. Now, obviously, the standards of care 8 is not within the DSM, and that those are two totally different entities. However, when we look at the way just nomenclature has changed, or the diagnoses have changed over time, we had transsexualism in the DSM-3, which was from the 80s, and then in the 90s when we had DSM-4, that's when the diagnosis shifted to gender identity disorder and its subcategories, and then we shifted into DSM-5. And certainly there's a long history to how it came about, and we can go into those details some if you'd like. But the idea of shifting from gender identity disorder to gender dysphoria in 2013, that was a fairly significant shift. Gender incongruence is something that, if you look ahead to some of the future coding, that I think there's hopes to shift even further, where it's no longer even considered something that requires distress to treat. That gender incongruence, it's we don't need to be looking towards distress or symptoms for treatment. It's that if someone might better align with how they feel about themselves, then they need to be provided certain interventions. So this is a slow creep of language over time. And I think part of it is, in some cases, it's an overuse of and overvalue of labeling. And then I think in other areas, this was an attempt to destigmatize. And I think in some ways it was meant to be more helpful for patients to feel like they could come and receive care. That there were areas in medicine and psychiatry where there was shame involved, and people felt like they couldn't reach out, couldn't ask for help. And certainly, obviously, we want to address that. By no means are we in our study or any of the work that we do are we saying that any individual struggling with any distress related to gender or otherwise, that distress is not real. It absolutely is, and can be very, very severe, very debilitating. But as you can see with the SOC 8, for example, now we shift even into, well, there's an incongruence, and there's not even distress required for treatment.
So that sounds like the creep towards embodiment
Right.
goals, where it's more to do with just, what how you want to be perceived, but yeah, there's no extreme psychological distress, which I'm assuming was part of the criteria in the past.
Mhm.
I think that this body embody sorry embodiment goals has been going on for past couple of years, as more and more of these systematic reviews came out and they showed no benefit at all. The more the gender clinicians leaned into these embodiment goals, it's fascinating to see how they did that. I was going through the Chen 2023 paper that came out in the New England Journal of Medicine. And I was going through their study protocol. It's a fascinating document, 140 pages. And they go through the list of changes one by one. Their original study protocol changes slowly, slowly, slowly over. I think there were 21 amendments finally to completely change whatever they thought they were going to see. And then when they did not find, I mean, it's a fascinating subject, the way they have slowly changed the goalpost over time.
Well, and I think to add to that, what really caught my attention early on when I began studying a lot more in this area is that This was the first time I had ever seen, and especially with children, but in really in any area that we look at altering a healthy body in a given moment in time, right? That obviously your concept of self grows and develops over a lifetime, but we are going to alter a healthy body to better align with a child's version, and a lot of times a very underdeveloped or immature version of themselves in that moment, using permanent interventions, that will alter things forever. And so it's just a that has not ever been considered medicine. It's not safe. It's not. We're now seeing not effective. But it truly to alter a body, and I think that's where you're looking at that embodiment goal. And it's ever changing over time. But a lot of times, what it can do is very much lock in a child or young vulnerable adult into a very concrete version of themselves, and then cannot move through it, and grow and evolve, and mature.
So I've spoken with clinicians. I spoke to this one clinician, and I was talking about this exact point, and I said, I was talking about, what the role of a physician is, and his response was kind of like, "Well, that's a good question." This was a
Okay.
yeah, a nurse, but it seemed like even the definition of what medicine is and what medicine provides is up for grabs at this point because maybe it's about making someone happy. So sorry, I'm going to go back. Jill, you're a psychiatrist,
Mhm.
Dr. Schwartz. When you were in medical school, what did you learn? What were you taught about gender identity disorder or whatever the nomenclature was at the
Sure,
time?
and
The prevalence and the population and the treatment.
sure, and that's, it's interesting. I finished my residency right as the DSM-5 was coming out, and so it was a really interesting time to, kind of have one foot in academics and then one foot in private practice, and it. I think one piece of this that I think we really have to not only share with patients but with clinicians, and we are taught this obviously in medical school residency, that the the DSM, or the Diagnostic and Statistical Manual, is a very, very think about it as a very basic roadmap. It gives us, when I'm talking with patients, I'm talking about, okay, if you meet criteria for a certain diagnosis, it doesn't automatically mean that you actually have that particular diagnosis, but also it doesn't define who you are. The quote that I love to refer to is, the roadmap doesn't equal the landscape. Every individual is a very complicated system, a very complicated human being that's evolving and developing over time, not just intrinsically, but then also in relationship to others, to community, to their future. So when in medical school and residency, we are absolutely learning criteria. There's a lot of just, okay, we've got to learn the basic maps first. But I think there was that reiteration constantly that you always have to be looking for, what else could be causing distress, what else could be causing, if someone comes in and says, well, I have this diagnosis, and I know I do, I've looked online, or I've heard it on TikTok, I check all these boxes, I meet criteria, just give me this medicine. That's not how how a psychiatric evaluation and then working through the diagnosis and treatment works. It wouldn't be safe. It wouldn't be effective. And that's more of a vending machine approach to treatment. And I think you said before, well, maybe it's just the job of medical providers or clinicians to make a patient happy. And absolutely, that cannot ever be our job. Our job, first and foremost, is to make sure we always are looking out for the safety and well being of the patient, and not just in that particular moment, but also throughout their whole entire lifetime. So, any intervention related to gender or otherwise, absolutely you have to consider repercussions, side effects, outcomes, not just, in the next few weeks or months, but throughout their lifetime. But then also recognizing that all of those diagnoses and the different criteria that you are looking for to possibly make a diagnosis. Remember, the first time I'm meeting with a patient, I'm going to know the least about that patient in that very first encounter. I learn more over time about them, and we learn together just what it is that they're struggling with and why. And so to think that, you immediately rubber stamp a diagnosis based on someone's self-proclaimed description of a set of symptoms, that again, that's not how I think the Diagnostic and Statistical Manual was ever meant to be utilized, and it can be very harmful when it is. So I think over and throughout all of our education, you're constantly taught to be very aware of all of the different things to look for over time.
So and that's how you were trained.
Mhm.
What sorry, what year, if you don't mind me asking,
Oh yeah,
what year?
no, my I finished residency. My path to medicine was I was in med school and residency later on. So but I graduated in 2013. So it was truly right when the DSM-5 was coming out.
Okay. And
Yeah.
so they actually addressed, I mean, they talked about gender
Mhm.
incongruence or dysphoria or whatever it was at that time. I mean, were you taught that it was rare? Were you
Yes.
taught
Yeah. Oh, absolutely. And I
that
think part of it too is, yes, you look at prevalence, you look at all of the different possibilities in terms of a differential diagnosis and ruling things out. But I think also what you have to look at is at the time, it was really exciting because we were getting to be, finishing our education and our residency as as the DSM-5 was coming out. And so it was interesting to see changes. But there's a lot of flexibility, especially right when those transitions are happening. The DSM, for example, it only mirrors codes, for example, for when you're coding for insurance companies or coding for the diagnoses. So one of the things that we look at is the flexibility in utilizing the diagnoses from the DSM-4 TR into DSM-5. So there's a fluidity of that, but not this rigid. Okay, based on name only. Here's what this is. Does that make sense?
yeah, yeah. And and do do you have an idea, a sense of now of what it's like for psychiatrists now who are training, what the difference is?
You mean in how they learn the diagnoses and the criteria?
Yeah, just I mean, what they learn maybe about gender dysphoria specifically. So, it sounds like there wasn't this big focus on gender dysphoria being um, a prevalent or permanent. I mean, maybe I'm putting words into your mouth, but
No, no, no.
comparing what psychiatrists are learning now about gender dysphoria or distress to what you learned. What are the how has that evolved?
And I think in terms of what they learn, when you look at and compare side by side diagnostic criteria in just the DSM, for moving into five, there's not a tremendous amount of differences when you look at the different criteria. So when you think about criteria and you're learning those, again, these are the things that are you're looking for, scanning for at all times. When you're seeing a patient that's new, someone comes in, they have distress, and you're trying to tease out, okay, well, why is this occurring? Is this situational? Is this someone who struggled with an anxiety disorder? And we're trying to figure out, how best to treat. And that's kind of, I think, the main thing to keep in mind is these roadmaps, for example, these very basic criteria that we're looking for. That's just the beginning. So we're looking for them and then exploring all of the different possibilities to get us to, okay, what are the best treatment options? How can I help this patient in the best way possible? And especially with kids, I think we've always looked at it in terms of what's the least invasive intervention that I can look at. Can we utilize psychotherapy alone and work through some of the challenges that a child may be concerned about, or is there interventions that we can look at that are very low risk, and start there? And can we start with very low doses of low risk interventions, the least number possible, that's still effective, and then move forward through, if we need to move into more significant treatments. But at the end of the day, the approach is the same. But when you look at just what you're being taught about criteria, there's not a lot, I think, that's different. If that again, if that makes sense in terms of describing what it is you're looking for, the concern is, or I guess in my opinion, the concern is the shift into, okay, if we're no longer going to look for distress, if it's just if someone is coming in and saying, I need medicine to better align with how I feel about how I see my gender, then what are we doing? What's the criteria to treat?
Yeah, it sounds like a very different mindset around your patient, wh- what you're there for,
Hmm.
how you're looking at their symptoms or their concerns, right?
Right.
Yeah. Um, so I want to get back to the statistics a little bit. ML, the WPATH link researchers, so they estimated that fewer than 8 out of 100,000 people would need medical interventions for gender dysphoria. But the JAMA pediatric study found that 100 out of every 100,000 teens had received puberty blockers or hormones. So that's an order of magnitude more than the WPATH estimate or of who would need these interventions. So can you bring those numbers into into reality for us? Like, what does that mean? It's really hard to conceptualize what that means in practical terms.
Right, right. It is indeed hard to visualize a 22-fold increase. So think of it in this way. Imagine the established clinical population, the ones, whatever the clinical population is as per WPATH, the 5 per 100,000. It actually, like, depending on the studies, I looked at them, the individual studies, they vary all the way from 1 in 100,000 and maybe an outlier of 30 per 100,000, but most of them lie in that 5 to 7 range. So think of this 5 per 100,000 is a 500 square foot studio apartment in Manhattan. Okay, what the JAMA paper found is the equivalent that the of the apartment suddenly exploding into a 110,000 square foot complex. To be clear, the entire White House before the expansions and everything is only 55,000 square feet. So what they have built is two White Houses in the space of a studio apartment, and then claiming, oh, this is just a small renovation going on. And they're looking at us and in the eye and telling us, oh, this is a very small number. So that is the that extent of that order of magnitude difference that we're talking about.
Well,
Yeah.
and also what they're talking about in terms of just that order of magnitude, think about what that says just to anyone trying to manage the health and wellness of patients. It's the idea that in any other situation, if there was a treatment that we provided, let's say it's a very, very common, very proven treatment that we provide often, if we looked at, well, clinically, we there's diagnosed, in a certain range, all of a sudden there's this giant magnitude of increase in treatment. What does that say, or what would that say to to providers? And in any other world, it would say, oh my gosh, there are far too many people receiving these treatments. They're just handing them out. There's no criteria. There's there's a great misuse, and that's not in this situation. It's kind of been the opposite. It's, well, no, we just need to loosen the criteria so that anybody that wants it can have it, and that it doesn't make any sense in terms of protecting safety and health and wellness of any of these patients.
So under
And remember this, this 22 times this number that we found, this is based on insurance claims where they were diagnosed,
Hmm.
where those diagnosis was made, that there was a gender specific diagnosis. There are papers that suggest that, for example, in the a paper that came out from the University of Iowa hospital records that suggests that most of the time they were, for insurance purposes, so that the insurance pays up, they were diagnosing it as that E34.9. Lauren, you might be able to speak of that. So endocrine,
Endocrine disorder
yeah,
unspecified, or not, right.
unspecified.
And that is and that is something that's a really good point, that yeah, the numbers that we could see right there, or but that the study was referring to, is were truly only when the diagnosis was documented and the treatments were paid for these kiddos. So absolutely, the number is far greater.
And the other thing, sorry, the other thing to point out is that this number that you find is the kind of a average number across the
Mhm.
nation. So that means there are places which have numbers much lower. There are places that have numbers much higher. So just as a point of reference, I mean, if I just looked at the census numbers and find out, okay, so there are 340 million people, 9% approximately are between the ages 13 to 17, and then 0.0046 or 0.005%. That number, in the entire country, the number of adolescents who would be getting hormones would be about 1,500. Okay, at the low end, and maybe 2,200 at the high
Mhm.
end in the entire country. Think of the fact that in the Children's Hospital Los Angeles that closed recently, they were servicing more than 3,000 families. It's one city having more than the number of children that could be medically justified per WPATH
Right.
guidelines. So that was the extent of overprescription that was going on. One
And we're
city,
also not talking about
one clinic in one city.
overprescribing something that's a well-known evidence-based treatment protocol either. We're talking about something that absolutely does not have that demonstrated effectiveness, or an evidence-based demonstration that this is a safe, effective treatment. So that's an even bigger challenge that we're facing.
Well, if you don't have a diagnosis, it's hard to focus on a treatment for it. So, I can we talk a little bit about that? I wanna go back to that, and that coding. So these patients, if they were coded, if they're if in the terms of the data, the JAMA data,
Mhm.
what was the h what or the insurance data, what was the coding that would qualify for these interventions? Was it, could you get a gender dysphoria diagnosis? Why weren't they just coding it as clinically diagnosing them as having gender dysphoria? Why go to the that vague endocrine disorder diagnosis?
So
I guess for insurance purposes, I
mhm.
mean, make sure that many insurance companies might not be willing to pay if it is, gender kind of a disorder that is specified. But maybe Lauren can speak on that more.
And it's a difficult question to answer in terms of why, as a particular physician, let's say, might code something differently. If, let's say, an individual meets criteria for what the diagnosis we have right now in the DSM-5 is gender dysphoria. That's what we have to work with. So if they're going to work within the framework, that's the diagnosis. An unspecified diagnosis is truly when you're trying to figure out what's going on and you're trying to see, okay, well, they don't quite meet criteria for something, and we're still trying to work through differential diagnoses. You might use an unspecified diagnosis to maybe have an umbrella there to until you start to work through and get to a more specific diagnosis. So unspecified isn't meant to be on there as an indefinite diagnosis. It's not, it's there to demonstrate, okay, we've got to look further. We've got to find out more about what's going on. But I can't speak to why someone would put that diagnosis down as a reason to justify using any of these treatments and then receiving payment for it. That gets into a whole different kind of is it, is it fraud? Is it, that's not, so I think that gets into a very muddy area.
But the JAMA study, that only
Mhm.
looked at the gender dysphoria.
That's right.
Correct.
That's right.
Yep.
This is specific to gender dysphoria diagnosis. And so this is verifiable. And this came from, a group of people who are, very big affirmists, if
Yeah,
I can
right.
call them that.
So in talking about those numbers, then we have clearly we have a vast undercount. Plus, you have places like Kaiser that are not going to be included in this study.
Right, right. But we are the numbers that they're talking of is a prevalence rate. So it is, there's a denominator there. So yeah, so the rate, unless it's possible that Kaiser is doing it at much higher rates than we know of. But this is based
Mm,
on
oh,
the
okay.
published rates, the places. Yeah.
Um, so you talked about, we have this over medicalization of this cohort. Under normal circumstances, what mechanisms are in place? What would happen if this was presented under other circumstances? Is there an organizational structure? Do the medical systems have structure that would intercede and say, clinicians, we're over medicalizing. Let's be careful about this.
Well, there should be, and there are existing entities. Everything from our national medical associations claim to do some of that. Our state licensure boards are there to do that. Our and there's the regulatory entities. Unfortunately, I think it seems to me this is somewhat of a, it's like where everything kind of got flipped on its head. It's the idea of, okay, we need to make sure we're protecting children and we're protecting a healthy and well developmental process for their lives. And in this particular situation, it's the opposite. It's that this is life saving, necessary medical interventions that have to happen as soon as we have the diagnosis, or they're going to commit suicide, and immediately intervene. And I think it's just from a regulatory perspective, I think that's one of the reasons why I'm involved in this is it's not happening. We're not seeing the involvement of the physicians regulating each other, the medical boards getting involved, and sadly I think that's when we see legislation get involved. There's a lot of different states now um, issuing all kinds of bills to help intervene because physicians are not practicing safe medicine. And I've not ever been a big fan of politics and especially legislation regulating medicine. But when physicians are out there practicing very unsafe, life altering, and devastating practices, and they won't stop even though the safety and harm signals are there, I think the legislators have to get involved. And they have a duty to protect kids in each state. And so I think that's what we're seeing happen. So to your question, yes, there should be regulation going on at all times. And it's not happening here.
And was there any reaction at all from the medical societies to the JAMA Pediatrics findings? Was there anything?
Well, I was reading the NPR news item, and the only thing they said, there's major medical associations in the U.S., including the American Academy of Pediatrics, support this care. And then there was somebody who directs the LGBTQ healthcare policy at the Health Research Organization, KFF, and was not involved in the study, but she was impressed by the sample size. I couldn't get what part she was impressed
Mhm.
with, because uh, essentially you're talking of a sample size which is 20 times larger than the population size. No.
Yeah, and I think that's been something that we've seen, just a repeated kind of mantra throughout a lot of the different organizations, whether it's my own professional organization, the American Psychiatric Association, American Medical Association, American Academy of Pediatrics, that repetition of this is safe, This is evidence-based. This is necessary. This is life-saving, just over and over. And we are in full support of gender-affirming care, including puberty blockers, cross-sex hormones, and surgical interventions. And it's just been across the board. We've seen it in, you know, amicus briefs presented even in Scrimeti, from all of these same medical associations. We see it in response to any studies, whether it's the CAS review or, other, great studies that the HHS report that came out, all of these medical associations that have said they're there to represent all of these specialties, and they're here to protect patients and protect health and wellness. They're not doing it. They're doubling down on gender affirming interventions.
So
The APA was so bad with that HHS review. I mean, it was embarrassing
Yeah.
to see their review.
Yeah. And I have, when I was in, speaking of, my training and my residency, I was proud to join the American Psychiatric Association. I'm a fellow of it. It's done some wonderful things, and I was really, really disheartened by their response and by their response to a lot of this. So my hope is the more that we can help present these numbers, like these help present that there are accumulating harm signals over, that we're seeing more and more of, that it's a small, very rare treatment that's occurring, and it's not. My hope is someone will listen. It doesn't seem like any of the associations are at this point, but I don't want to give up. I think we just have to keep fighting, because at the end of the day, these are the lives of children, period.
so the for that HHS review, the APA panned it, right? They said there was no credible evidence to support um, the hormones to support what they said, right? Um, and,
Right. I mean,
and do you think most APA members agree with this, with what they had to say?
No, I don't think they do. I think it's a very small group that's of the APA that's misrepresenting and absolutely abandoning their rank and file. And that's been going on for a while. We've been trying to bring attention to it. I mean, even in, you go back to 2023 and 2024, but the American Psychiatric Association, their publishing house, published a book, Gender Affirming Psychiatric Care. And we wrote a letter. We've written, um, just asking, is this truly representative of how you feel patients should be treated? And we did not get a response.
Oh, okay. Um, all right. Well, yeah, that's I'm surprised that the medical organizations, seeing that this is turning political and that now there are these bans and legislation, that they wouldn't want to avoid legislation stepping into medicine, and they would be more aggressive about um, monitoring and reducing this kind of negligence.
Sure. And my hope is that, I think the more we can present cases, the more we can present evidence, the more that we can try and have conversations about it and discussions about it. The goal would be to provide every single patient, including those distressed about gender, with the best possible care. And that's not what this is. In this area, we've just seen such ex- an exceptionalized approach to providing substandard care to a very vulnerable group of patients, and that's just it. My hope is it starts to become more visible. um some days it feels like, okay, we're making a little bit of progress. We're hearing from some different medical groups, maybe, or we might hear from different insurance companies, someone having a different conversation about it. And then it feels like then we take 12 steps back when you see what, like, the American Psychiatric Association said when they were invited to participate in the peer review process of the HHS report, which it truly is a fantastic document. If anyone um, has read through it, it's wonderful. They did a really, really great job.
Yeah, I realize it just took make sure everybody knows. So the HHS was the umbrella review done by 9 researchers in on, so it was kind of an even bigger review than the typical systematic review. They looked at the literature, and then they did a peer review, and then they responded to the peer review, and a number of the medical associations declined to participate. APA basically panned the entire report.
Mm-hmm.
So,
And one of the points that they said was, here are 16 different studies that you didn't look at. And it was such a stupid thing to do, because the authors of the HHS report, they just came back and said, no, we talked about them. See,
Mm-hmm.
just read chapter 5, go into this section. There are these 1, 2, 3, 4, 5, 6, 7, 8, 12 reviews that we talk about. The 3 others that you talk about are about adults. That doesn't concern the pediatric population. And the 16th one that you talk about came out after our HHS report. And so, look, if you want that, we reviewed that now. It was so obviously stupid of them
what embarrassment.
that they wanted to talk
Sure.
about something that could be so easily verified.
Well, and I think also not just stupid, it's irresponsible, because I think of how much the associations, whether or not they deserve it, they are absolutely what they have to say about things. Their members absolutely look to them for guidance. Patients and families look to them for guidance. They are the experts in the room when there's litigation. They write the textbooks. You go back to medical education and residency, and the American Psychiatric Association's publishing house publishes the Diagnostic and Statistical Manual. So it's also publishing this gender affirming psychiatric care book. So again, you're talking about an influential association in all aspects of mental health and psychiatric care. And so then to present this comment about peer reviewing the HHS report, it's devastating, I think, in a lot of ways, because, or at least it's very disappointing that they would put something out there that is so irresponsible to say, don't look here. The work that's been done doesn't even make sense. We shouldn't even look at it. So you guys shouldn't either. Meaning they're rank and file psychiatrists that are members and look to them for guidance, and the students that look to them for education. Um, it's very, very frustrating.
And it also makes the entire organization, I mean, who will believe them from now on? I mean, don't they think about that? It's devastatingly stupid in my mind.
Yeah, I think, and my fear is truly who will believe it. Meaning, not how could anyone, but so many people will lean on their opinion to discount a very, very strong, very comprehensive report. So it's, yeah,
Well,
disappointing is
right.
is an understatement, but
I think that that's part of it. I mean, how many people will read the response to their statement? The
right,
statement itself is the action. It doesn't matter whether it's true or not,
yeah,
because there is not going to be the follow through. It's accomplishing the mission of discrediting the report,
hmm,
is what it was. So, which brings back, if we get back to the JAMA pediatric study, so the paper's motivation was political, right? It was the
Yeah.
letter, the research letter accompanying the study, refers to state bans on uh, pediatric gender intervention.
Hmm. Hmm.
And the headline of the press release of the study was Gender Affirming Medications Rarely Prescribed to US Adolescents.
Yeah.
Rarely
Yeah.
prescribed. So this was not about medicine. This was about politics and and um, statements that could be quoted. So the lead researcher was Landon Hughes, and the NPR uh, statement from him was, he said, I'm going to read this, it's a very, very small number of people that has managed to eat up all the oxygen in our political discourse. So Hughes is basically saying, what's the fuss? It's only a tiny number of kids anyways, a very, very small number. So, for both of you, can you think of another example of such a politicized medical issue? Is there anything that compares?
Um, I can't think of such a
Mhm.
politicized issue, but I can definitely, the example that I was giving earlier, if Philip Morris came up and said, there are 340 million people in the US and only 100,000, one in, I don't know what that number would be, but, much, much lesser than 1% die every year from smoking. What's the big fuss? Why is it taking up all the oxygen in the room?
Right.
Literally, in this case. But you would immediately claim bullshit. And I mean, Landon Hughes is doing the exact same thing. He's using the entire US teen population as the denominator to make the medicalization rate that is actually 2,000% higher than the baseline, uh, and make it look rare, quote unquote. It's a cynical trick, and frankly, this was published in JAMA. My goodness.
And I think what I struggle with is any physician, any person out there practicing medicine, it doesn't matter how small a number is. If a patient is being harmed
Mhm.
and you are aware of it, you have to speak up about it. This is there's no acceptable number of patients or and children that you can harm, and then, oh, okay, now we can talk about it. So to say that there's this small number of people, and you guys, this is not that big of a deal, look away, to me, I guess I just don't understand the point of what the
Mm.
statement would even
Yeah,
be
yeah.
there for. At the end of the day, I don't care if it's one person being harmed. I don't care if it's one child put in harm's way. If you are aware that harm can be done by interventions that you're providing a patient, what are you doing?
Yeah.
And if you're aware that a type of care is being provided that's causing harm and you're being silent, well, you're now complicit.
Landon Hughes produced a paper back in 2022 where, if you go through the appendices, you can find out that it showed that um, the transgender, trans identified males on, uh, uh, he didn't specify, he didn't go into the details of whether they were medicalized or not. But this we know from the data, that by the time they're 50, they're more than 3 times likely to die than somebody who is not medicalized. Um, so he knows this. He published this paper just 3 years back that this causes harm. Um, and yeah, and for him to come out with such a statement, it's shameful. Shameful at every level.
Um, I want to get back to the number a little bit. Um, we talked about the denominator, that by using this giant denominator, it it artificially reduces the prevalence, right? What would have been
Mhm.
an appropriate denominator to use?
Okay, so it's an interesting question. Here's something that happened in that NPR interview that's not there in the published study. Landon Hughes actually made a slip, which is a kind of a confession, which wasn't there in the paper. He told NPR that his team identified 18,000 youth with gender dysphoria diagnosis, but only medicalized 2,000 of them. Okay. So he thought that he was kind of bragging that, it's not that everybody who gets diagnosed, we just give hormones to them. Uh, but think of the math. We already know that the 2000 that they were diagnosing represents a 20 times higher rate than the WPATH established, experts established baseline. So what he's admitted in that NPR interview, that the number was actually 9 times higher. It's 180 times higher. Um, so the the so what that number should have been is the number who the denominator should have been the number of children who were, after the battery of tests. In Finland, for example, they do it over a year, multiple times, meeting not only the child but also the parents, finding out all other causes, and only after that, if nothing helps, then they diagnose somebody with clinical gender dysphoria. So that should have been the denominator, not all the adolescents in the 13 to 17 age range.
Right.
Did I
Got it.
answer that?
Yeah. Yep.
Yeah.
That answers it. I'm going to post a link to that NPR interview piece in the thread. So
It's an astounding piece. I mean, and I don't mean it in the right way, astounding, but yeah.
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 Okay, so I want to flag another factor in the JAMA pediatrics research. And, we don't bring it up a lot, but the money aspect. The researchers were from Harvard and Folks Health. And Folks Health
Mhm.
is a for-profit telehealth company, makes money prescribing hormones and surgeries for trans-identified patients. So that sounds like a massive conflict of interest. So what happened to all the hand-wringing about pharmaceutical companies sponsoring medical research? And that used to be important. What, Dr. Schwartz, is that out the window now?
No, not. I don't think it is in terms of the ethical practice of medicine and standards that we do have in medicine. I think what we're looking at though is the difference in what the standards are versus what's happening. And so I think that's, of course, conflicts of interest are hugely important, and we want to be able to know about them and make sure we're that's not happening. And at the end of the day, we've got to get back to centrally practicing medicine and not practicing whether it's politics or it's practicing activism or it's practicing a money chasing pursuit. That's not what medicine's about. So that's what I stand by and I practice. And my hope is shedding light on this will help many more people get back to practicing medicine and demanding. And I think it's way past time that clinicians, we have to demand from our licensing boards, from our associations and our medical and specialty associations, that they do better, that they get involved, that they start to recognize this, not just in small circles, but being able to speak to all of this, and what's been going on. So no, I don't think it's gone out the window. It can't. Um,
I think Lauren was saying earlier about
mhm.
vending machine medicine, and I don't think there's a better example of vending machine medicine than Folks Health. I mean, if you go to the website, I'm right now on their website. It says there's a running thing in the bottom, says, insurance or not, get medication discreetly and easily, beyond labels, exceptional care, appointment in days. Uh, I mean, what is this?
Mhm.
My goodness.
Yeah, it's grim. And now we have uh, gender GP moving into the US.
Yeah.
That's a whole another topic to worry about.
And you have people from Harvard, collaborating with them. Is that what we have reduced ourselves to?
Not all of us. I would say there are, and I hope in some ways, I know a lot of this seems grim, but I think also recognizing there are thousands of doctors out there now fighting, pushing back, feeling like they can actually start to speak out about it, where even a few years ago, I think people felt like they couldn't speak up. They couldn't, address what needs to be addressed. And my hope is that more and more people will start to stand up, start to speak out, start to fight for these patients that deserve better.
Mhm.
So what about the the fall of peer review? So that study in JAMA was peer reviewed. Um,
Yeah, yeah, yeah.
that's a whole nother range of.
Oh, yes. Oh, yes. I mean, peer review. This itself is an industry of sorts. Uh, you know, you publish something that is the flavor of the moment. The peer review becomes a joke. You publish something that is not the flavor of the moment. Um, you can try anything and it won't get published. You would have read the paper that came out by Jay Cohn recently about their experience trying to get some corrections out of New England Journal of Medicine, JAMA, others. None of them get published. Why? Because what they try to point out is actual numbers, actual science, actual evidence that goes against the grain of what is being said in those quote unquote studies. Um, it's absolutely grim. I mean, my goodness. I mean,
It's yeah,
you
it's
you can't you can't be sure ever that a paper which has been peer reviewed actually has merit or not unless you read it through and through.
well, and I
Uh,
think also to even look at what, as a clinician, every day that's what I look to. I have to look to peer-reviewed studies to provide guidance in, okay, what's the best possible treatment protocol or steps that I need to take with each individual patient. So it is very, very important to clinicians. And so I think as grim as it is, recognizing also that how do we get back to being able to rely on it? We talk about the peer reviewed process. And again, I know I keep referring back to this, but it was maybe the first time I really was looking at it in the face in terms of peer review. When the American Psychiatric Association's publishing house published the gender affirming psychiatric care book, their publishing house not only brags to be a peer reviewed process, it's doubly peer reviewed. On their website, it says that it is we take pride and we have the most rigorous process. We peer review everything that we're considering for publication, and then before it is actually published by our publishing house, it goes through another full peer review. And so, what that says to practitioners or clinicians is that you do not have to go and do all of this research yourself or read every single study. We've done it. So, everything that we put in this book, or everything we put in this guideline, or everything we put in this journal, you can know that we've already done that. We've already decided this is safe to use with patients.
So is the problem widespread? Should we be worried about our general medical care that clinicians are getting bad information, or is this again, is this an outlier and it's just this strangely politicized social justice medical movement?
My answer would be yes to both, right? That's not an answer, but I think the idea that are there widespread problems? Yes. Um, is it something just specific to gender alone? No. What I think this has become is a very clear example of how much harm can be done when this type of literature laundering is happening at the cost of patients' lives. And so I think my hope is in some ways it can be used as maybe one of the most glaring examples of why this has to get better. And maybe I'm forever an optimist to a fault, but I do hold on to there are so many incredible researchers worldwide, medical researchers. There are people out there doing tremendous work, and they're doing it despite what the current peer review process climate is, and that can't stop. And so my hope is, again, this has to get better. The alternative is not something that I think we want to consider.
And if I could add something, I mean, I come from a world of peer reviews, not in medicine, uh, but as Lauren said, I mean, that's what you rely on. And once you get to distrust this, then it becomes it becomes a entire jungle out there, because you don't know what to trust.
Mhm.
If the New England Journal of Medicine could publish something like the Chen paper in 2023, where they, in the abstract and in the final conclusions, they don't mention their absolute null results for the males,
Mhm.
and the clinical results, which are completely insignificant for the females. They don't mention the fact that the study protocol has been completely changed wholesale. And finally, it was kind of a Texas sharpshooter thing. There's the data that shows correlation. Let's claim it as let's claim it as the main result, kind of thing. If that can happen to the New England Journal of Medicine, something that was published first in the 1800 something, what can you rely on? And that's the main problem. It's not gender medicine per se. You start disbelieving anything that comes out.
Right. Well, that's what happened with the media, right? I mean, the media is always trumpeting, it's peer reviewed, it's peer reviewed. But even for this, seeing that the media did not and has not covered this honestly. Um, so just like with the clinicians, how do I trust that my doctor really knows what the best treatment is for whatever I come in with? How do we trust the media when they have had played such a big role in this like this NPR piece, which we'll
Right. I mean,
use afterwards.
this piece wasn't very difficult for us to write. I mean, you just had to look at numbers. There's a number in the top, there's a number at the bottom. Divide the first by the second. Find out, and whether it somewhere is in the ballpark of making sense. And nothing made sense there. You look at it the first time. The first time I read it back in January, immediately something went off. Anybody with common sense would say this is wrong. This seems so wrong. There's the graph that shows exponential rise, and you're still saying that these numbers are very small. This seems wrong. And for them not to do that little bit of work, what is journalism for?
And I do think also, I mean, to recognize that within medical training, we have you have statistics classes, you have you know you have classes that are dedicated to looking into evidence-based medicine and how to review studies, how to go through. So that education is built in, and I know it still exists, it's still there. And so um, I think that's also maybe a little bit of some clarification in terms of, if you're seeing a provider, if you're seeing someone who is just quoting NPR, it may not be the best person to be seeing as a safe physician to have your healthcare in their hands. So I think realizing that, yes, these studies, maybe they're being published in peer-reviewed journals, but if, as long as, if a physician can look at those journal articles and say, well, yeah, but the data doesn't make any sense here. We are trained to do that. Now we can't. Um, I don't think there's an argument for just letting the whole process go. We need those research studies. We need those guidelines, and we need them to be evidence based. And like I said, there are people doing wonderful work in so many different areas. But we've got to keep making sure that people are aware, what you're being told in headlines, or media, isn't necessarily medicine.
Oh, well, the people rely on those on
Hmm.
the media to interpret, right? They're not gonna read the studies, but they do rely on the media, and when we have NPR trumpeting that study, um,
Yeah,
Right.
yeah. And I looked up after that, the Selena Simmons Duffin. the one who presented it, she went to Stanford, for goodness sake. Oh,
Um, so, um, Dr. Schwartz,
Mhm.
can this paper be a weapon in the fight against this medical scandal? Can it have an impact? You know, we keep waiting for things that will shake clinicians and the media out of their stupor on this. Could it have an impact on how psychiatrists treat gender stressed patients? What's the reaction been so far? Have you gotten any reaction from your colleagues? Is anyone picking up this paper? I think it's hard because it feels dense, you know. It's
Sure. And well, and I would say I'm not I couldn't comment actually on the response. I've talked to, people or colleagues individually about it. And I think what always surprises me is how many people don't realize how the way things are being presented and misrepresented, and the numbers are being presented in a very misleading or just completely incorrect way. And so, but what I hope is, and what I've found is the more information I can provide, not just to clinicians, not just to the media, but I think most importantly to patients and families. If I can create or help them to understand things better, if we can educate anyone and everyone we can on what this is and truly what it is not. And that's safe, effective, proven treatment that's medically necessary and life saving. That's not what it is. And so if we can show through the data that's there, it's been published, they've published it, whether we like it or not, they have published it, but then we can utilize that data and then present it to um, like I said, whether it's clinicians or it's legislators or it's parents or it's schools, we can say this is not um, representative of the solution to this challenge that these patients are facing.
ML, how do you see your paper being used?
um, I'll try to end in a hopeful note because I got increasingly worked up throughout this. Um, mm, uh, I think it's a tool for accountability. It allows a parent um, who obviously thinks that this is, who has the experience of being with their child 24/7 for 15, 16, 17 years, and suddenly the child says something which doesn't make sense. It allows that parent to ask the pediatric doctor who is going ahead and saying that, let's medicalize, um, to ask, WPATH experts say that you should see, you know, maybe in this city, one patient a year, and you claim to have treated 100. What diagnostic criteria were you using that those experts did not know about? It could be used by a lawyer to ask the clinic director that same question. Based on these prevalence numbers, in this entire city, you should be having 20, 30 kids across all clinics, and yet you seem to have 100 children in your clinic. What are the diagnostic criteria that you're using? Uh, I think that is something that they can definitely talk about.
And I think no matter what, whether the media says otherwise, whether state legislators say otherwise, whether an administration says one way or another, if something is safe or effective, if patients are being harmed, and we're showing over and over that it's in the data that's been there the whole time for any of these practicing physicians that are prescribing these interventions to children, that's been out there, they are still ultimately responsible. So you can't, and when you're facing a judge on these matters, it's not about whether or not NPR said they should prescribe it, or whether or not, you were told that, well, but WPATH said to do that. We've seen that already play out in court, whether it's in Bovie Marshall or in the Scrimeti case. WPATH is not doesn't have legs to stand on, and clinicians need to know that.
if I could take 1 minute, are we?
Go ahead.
Am I allowed? Yeah. So this you're talking about the media, and
Mhm.
one one person in the media that I really want to mention uh, was is John Oliver, and he once made the most common and laziest false analogy when he cited Julia Serrano, a trans-identified male, pointing to a massive spike in left-handedness. So I looked it up. The spike was a threefold increase over 100 years. Here, you're talking of, in terms of diagnosed gender dysphoria, 180 times the increase uh, uh, in less than a year, maybe, because the last review came out in 2019. Um, Landon Hughes was getting data from 2018 to 2022. Um, so and these are people who inform the public, and
Mhm.
yeah, no, I'll stop ranting.
Yeah.
I'll
Well,
stop ranting.
I think that's a painful one for a lot of us,
Yeah,
is to
yeah,
see how dangerous um, someone like John Oliver could be,
yeah,
because
yeah.
he has a tremendous amount of influence and he couldn't be more lazy and wrong.
And he claims to have done the research.
Well, and I think also kind of going back to what ML said earlier when talking about parents, that you've been there. You've been with your children for years and years, their whole entire lives, and you loved them before they were born, and you counted their fingers and toes when they were little bitty. Like, you are the expert in your child. So don't ever walk into an office and think that in any way, shape, or form, I don't care how many years of gender affirming education someone claims to have had, you are the expert. Um, you know your child, and you were there before that doctor was there, and you'll be there afterwards, and so you can rely on that.
Um, on that very um, true note, maybe we should go to some questions. I don't know if people want to queue up for questions for uh, Dr. Schwartz and ML. While people are doing that, I do want to mention, it's funny that it's such a common theme with this issue. The It's such a small number. Why do you care? Such a small number of men in women's prisons, such a small number of boys competing on girls' sports teams. Everything is in reference to this small, this mythical small number. And there doesn't seem to be a number there doesn't seem to be a threshold of, oh yeah, that's enough now. That's enough, boys. It's just always eternally small, and they just move the goalposts, like in this case. You know,
Uh,
this
uh,
is now defined as small. You know.
yeah. Just a month back, I read this report by ProPublica, where they, went through the records and found that 100, 170 U.S. citizens were illegally detained by ICE. Now, if you make it a percentage of the U.S. population, that's 0.000005, I think, 1 in 2 million. So, you know, I mean, do you think that that's a small story? That's a small number? Uh, no, I mean, anytime anything wrong is done, it's wrong. That should be the criteria.
Oh, absolutely. And I think no matter how rare a a bad outcome, a harmful impact on someone's life is, it doesn't rare doesn't play a role there. Um, Harm is harm.
Yeah.
Devastating permanent impacts on children's lives. There is there is not a number too small. Until that number is zero, we don't stop fighting. Period. And that's what medicine, and at the heart of the practice of medicine is, that every time that we see that something is not a good option for a patient, or okay, there's a harm signal here, we stop, we wait, we are cautious with that approach until we can figure out, okay, is this is it safe to proceed? And it's just the opposite in this field. It's just blaze forward, while all of these patients are being harmed. But to get back to the point of there's no number too small. I think that is a really really devastating argument in any arena, not just
Yeah.
medicine, but anywhere.
Well, in our
Um,
conversations, ML, you have mentioned the Tuskegee experiment.
Yeah, yeah, yeah. I mean, that wasn't a scandal because how many men were involved. It was a scandal because what was done to them. I mean,
Mhm.
if good, I mean, during that 2 year study of the New England Journal of Medicine, I keep on going back to that New England Journal of Medicine. For goodness' sake, they lost two children screened. Initially, they were not allowing anybody to get into the study. Two children were lost to suicide. They didn't stop the study out of 315. Compare that to the computed data in entire England. They lost. The rate was, I computed that from that study, 24 times higher.
yeah.
In the New England Journal study, and yet they did not stop that study. They continued it, and they finally kind of spun that story to be a positive story. I don't know
And I
how
think
they do it.
that's kind of anytime you hear us talking about this being an exceptionalized group of patients, exceptionalized in terms of why are we continuing to provide such substandard care, treatment, and research for this particular patient cohort? It doesn't make any sense. Um, and again, it just gets back to patients and parents deserve so much better than this. And it's up to medicine. I truly, I'm a firm believer in medicine and psychiatry and mental health. And we've failed patients, and we have got to turn this around. And it has to happen.
Um, on that, let's see. We have one questioner. Let's see. Oh, Kevin Waldman, who was with us a couple months ago on our last space. Yeah. Go ahead, Kevin.
Good evening. Uh, Dr. Schwartz and M L, thank you very much for what you guys are working on. I don't know. All right, so I have a couple thoughts. I'm a researcher. I do clinical research in psychology, and some of the work that we do is in the gender realm. Quite a bit of it has been actually. One of the things that's pretty shocking to me is I did a study at the University of Michigan in 2024, and I know for a fact there's at least 20 females there that are on testosterone. And so this figure, and feel free to interrupt me, by the way. Um, I was wondering, I've been coming kind of in and out of this live session, so forgive me if I missed this, but are you guys applying testosterone for young females into the number? Because I the 1 in 1,000 is I've read this as well. It's not accurate. It's a complete lie in my opinion. So I'm curious if the testosterone is something that you guys are also focused on, or if it's just puberty blockers.
This focuses on hormones at the age of by the age of 17, so it includes testosterone. But the number that you spoke of, it is very possible that many of these women who are on testosterone might have been coded differently for the purposes of insurance. So
Oh
uh,
yeah, yeah,
yeah, so we are not capturing, or the study by JAMA did not capture
yeah.
that. Yeah. So
One,
our study, what it shows is that even after those, possible undercounting, vastly undercounting because of miscoding, we are still at 20 times the number.
yeah,
And what Landon Hughes showed, we are at 180 times the number.
yeah,
And if you take that miscoding into account, I don't even know what that number would be.
yeah, yeah. Wow.
Um,
Um, I was gonna say really quick. I think part of it, like, because I do quite a bit of research on different topics that I think are intertwined with this. I think that if you have politics is so unfortunately affecting mental health and academia in many ways, and so I think I one of the issues that we have is people are so um, quick to jump on board with this because they hate Donald Trump and they think he hates it, or they don't realize I think the damage that is actually occurring, especially developmentally, which is what I focus on. With I focus mostly on young females that have transitioned to male, and what I'm learning is that so at the study that I did at the University of Michigan, I spoke with 11 trans female or trans men, women to male, and none of them had had any medical intervention at all, just socialization. But there
Mhm.
are at least 20 that I met at the University of Michigan that are on testosterone, and they refuse to speak to me. And part of
Mhm.
it is that their medical professionals that are helping them are telling them that part of this is you're going to have pushback and you're going to have people challenging you and to fear these people like me, which by the way, I'm a gay guy who's a researcher and I do research in the LGBTQ umbrella because I think it's toxic. And one of the things I try and do is meet with individuals. So I spoke with quite a few people that have transitioned socially, and they're the ones that are willing to speak because they haven't had the influence, which is someone like me as a researcher is dangerous. And so I think also at Northwestern in particular where I work now and where I'm a student at Northwestern, it's an affirmation all. So Dr. Schwartz, it's interesting how you said in 2013 you now it is as someone I'm studying I'm getting my license to do clinical counseling, it is 100% affirmation. So if a client comes in and says I'm 13 years old and I want to transition, I have to say you can. That's really
Yeah.
sad.
Yeah,
Yeah.
oh, absolutely. And I think there's, you mentioned the political side of it, but then you also have to look at when someone is young and struggling and they're looking to someone to be their, the trusted expert in helping them, right? They when they are told by that person, even if they're not suicidal at that time, that if you don't do this, you're going to become suicidal. You'll probably die because you're going to kill
Yeah.
yourself because you don't
Yep.
have this. So avoid anybody that's going to tell you otherwise, that you maybe shouldn't consider it.
Yeah.
To me, that again, it's emotional manipulation, and
Absolutely.
it's yeah, and it's not presenting options, and that's again, medicine and mental health. We have to get back to that we're there to, it's something that where it's almost the okay, here's the only possible treatment, so your only choices are to die or to permanently alter your body in a devastating way, and so yeah, it's a the affirmation only is really, really concerning. And again, I hope, I do talk to people in different academic settings and programs, and my hope is there are more out there that are, exploring this and being, becoming more aware of it. And I don't want to wait, for more and more people to be harmed, for the number to be so big that it's like we have to address it. It's got to be addressed now.
Yeah,
Um,
I agree.
And
yeah,
if I could
and
add something here, I mean that uh, I don't understand what Donald Trump has got to do or not do with medicine or science. I mean, by that logic, I mean Hitler was a vegetarian, so so vegetarian is bad now. I just don't get it.
right, and I think that's part of it too. Is medicine has medicine isn't political when you're practicing medicine. Politics have infiltrated every aspect of it, but that's very different than politically led treatment. And so I think again we kind of have to detangle that. And I don't care who is in the administration, I'm still going to prioritize the safety and stability and well-being of every single patient that walks through my door. That I don't see how that's controversial. But as we teach more new physicians, new therapists, new providers, that can't be forgotten, or medicine truly is lost.
Yeah. Um, all right. Thank you. Anybody else have a question? If not, we'll wrap up for the evening. Doctors M. Lal and Lauren Schwartz, thank you for your research. Thank you for explaining it to us in ways that we could understand it. Thank you for joining us. Um,
for having
we-
us here.
Well, absolutely. Thank you for having us. This is always a wonderful, wonderful group to speak with. So I really appreciate you guys giving us the time to do so.
Absolutely. We'll see you around the next study you put out. Do you have papers or studies in the works? Anything you can look
We do.
forward to?
We do.
Yep.
Do. Okay.
Not ever going to stop fighting until, again, the number being harmed is 0.
Okay, then we'll see you about the next one.
Sounds like a plan. Take care.
Very good. Hey, Carrie. Have a
Thank you.
good evening, everyone. Thank you for joining us. Um, and please do check out our website, diag.org, di-ag.org, and we'll see you the next time. Thank you.